Hi, good morning. I'm Dr. Ng here. Um, me and Dr. Chan are from the Department of Biomedical Imaging. We are both intervention radiologists. And I would like to introduce Dr. Chan, who is currently a fellow in training in intervention radiology. He's all the way born and bred here from University Malaya. He's a house officer, medical officer, trained in clinical radiology here, and currently a IR fellow. He's currently his current interest is in intervention oncology, and he also does a lot of PEDS intervention. And today he would like to share about parathyroid and thyroid ablation. As we know that intervention radiology does a lot of minimally invasive treatment, and this is one of the new services that we are introducing in our center. So let's welcome Dr. Chan.
Hello. Okay. Thanks, Wei Lin, for the kind introduction. Okay. So today the topic will be about parathyroid and thyroid ablation. And okay. So before we move on to the ablation related slides, right? This is just a simple reminder on the thyroid's reporting system. So what we use here is actually the ACR thyroids, the one in purple. Okay, the one in purple over here. And when you refer a patient to radiology for a scan, thyroid nodules that will be found will generally be scored and tiered and classified according to these 5 different tiers, either TR1, TR2, 3, 4, and 5. So 1 and 2 is generally benign. 3 onwards is suspicious. So 3 is mild, TR4 is moderate, and 5 is highly suspicious. So with all these classifications, you actually have these recommendations as well. So TR1 and 2, generally, we don't recommend any FNA. 3 onwards, depending on size. Okay, and a simple way of remembering this, if you refer for something that is a spongiform lesion, usually the score for max is about 2. Okay, because you can see here, spongiform is going to give 0 points. Echogenicity, most of the time, is going to be hypoechoic or isoechoic. So it's going to be 2 points max. Sometimes you can reach up to TR3 if it's very hypoechoic. So solid cystic generally is at least 2, the score. Okay, because 1 point from here and another point from echogenicity, the minimum point you'll get is 2. And solid lesions are generally 3 onwards because solid itself already contributes 2 points. Okay. The EU thyroids over here is just a comparison. Okay, but we generally use ACR thyroids. So, okay. So the indication of ablation, these are the 4 main reasons. Number 1 would be compression. Number 2, cosmetic complaints, high-risk patients, and refuse surgery. Okay, so generally, traditionally, we tend to do more thyroidectomy. Ablation is something new, and generally, the ablation, we only focus on benign lesions. So this is the practice guidelines that is published back in 2021. So you have the Korean, the Italians, Austrians, and the UK. And you can see if they have symptoms or cosmetic problems, it's all, yes, it can be done. The autonomous functioning thyroid nodules, yes, as well. And generally, this requires 2 benign results. So meaning when you see something suspicious, and a patient agrees for ablation, you need to have 2 HPA results that show that it's benign. So for the Korean and Italians, they only require 1 benign result if the thyroid score is low. So this is a rough, I would say a rough guide, management algorithm for benign thyroid nodules. So initially, when you see the patient in the clinic, you perform your examination, clinical history, and the biochemical test. Okay, and this is when you suspect a thyroid nodule. Then you send the patient for ultrasound, and ultrasound actually confirms the thyroid nodule. And patient agrees for ablation, then you need to do 2 samples of FNAC to get 2 benign results. And once the benign results are out, you can go for ablation. And after ablation, you have this follow-up of 1, 3, 6, and 12 months. Okay, to assess the volume reduction, nodule appearance, and potential growth. So why choose thyroid ablation? Number 1 would be thyroid gland is preserved. There's no lifelong therapy. And results are generally long-lasting. There's decrease in nodule volume, 57 to 77%, decrease in nodule volume at 5 years follow-up. Improvement in symptoms and quality of life. Complications, it's there, but it's rare. No incision scars. It can be done as an outpatient procedure, and it's minimally invasive. And what is thermal ablation? Thermal ablation, basically we elevate tissue temperatures high enough so that it creates irreversible cellular damage. And thermal ablation actually hits tissue to cytotoxic levels, which cell death is caused. And after that, it will be followed by coagulative necrosis and degraded by the patient's own immune system. So this re-emphasizes the thermal ablation, heating up tissue to cytotoxic levels. And for our RFA, our ablation over here, so the temperature that we aim for is actually between 60 to 100 degrees. That is where you actually get coagulation of tissue. Anything higher than that, you cause vaporization and carbonization. Okay, and when this happens, the ablation would not be effective. So thermal ablation generally covers two main types of ablation, which is RFA, radio frequency ablation, which is more traditional, and microwave ablation. So the difference between these two mainly is through the heating mechanism. So RFAs, you use electrical current, we relies upon tissue conductivity and ion content. Microwave ablation, on the other hand, uses electromagnetic energy. Comparison showing ground pad is required in RFA. Microwave, you don't need it. Heat sink is, I would say, more in RFA, less in microwave. Procedural time is also longer in RFA. Microwave is shorter. Ablation volume smaller and microwave is larger. Okay, more unpredictable because of the heat sink effect, and more predictable for microwave ablation. And pain as well is higher level in RFA and less in microwave. So in RFA, there's dissipation of heat in tissues adjacent to vessels because of blood flow that results in irregular and insufficient ablation zones. Okay, and microwave is generally more, I would say, more homogeneous. Okay, and larger ablation zone. This is mainly because of the Wei transverse energy. RFA is basically is due to conductive heating, and microwave is due to dielectric heating, which is direct energy transfer to tissues through the electromagnetic waves. So this is for solid lesions. What about solid cystic lesions? You know, as the solid component increases in a cystic lesion, the efficacy of ethanol ablation decreases. So traditionally, cystic lesions are ablated using ethanol, and we still do it. Yeah, so if you have something that's of a mixed picture, you need to have an aspiration of the content, and then you give ethanol ablation followed by RFA or microwave ablation. And if you only do ethanol ablation in solid cystic lesions, the recurrence rate is generally over 50%. So there's this study done by Su Chong, Hyun, and Wei, and you can see that they have a total of 221 nodules in 217 patients, and some are excluded, and they only end up with 107 patients which are predominantly cystic. So after ethanol ablation, 87, there's no recurrence, 20, there's recurrence. However, of these 87, there's 21 of them that develop delayed recurrence. And yeah, so these two numbers actually make up about 38.3% of recurrence rate. And some of these patients actually go for RFA. And after RF ablation, the therapeutic success rate was 100%, and volume reduction rate is about 87.8%. Okay, and delayed recurrence period was about 10 months plus minus 8.5 months. Okay, so this is a patient that they shared in their paper. Actually, in this first image, you can see that there is this cystic component of the thyroid nodule, and this is a solid component. What they did is they aspirated, they give ethanol ablation. However, 1 year later, this thing recurs. So after recurrence, they repeated the same ethanol ablation, but at the same time, they actually did microwave ablation of the solid nodule. And this is 6 months after ablation, you see no more recurrence. Okay, so for patient preparation, so according to SIR, the consensus guideline, this falls under category 3. Category 3 meaning it is high risk of bleeding. So because of that, you need to have these values. INR needs to be corrected to less than 1.5. If less than 50,000, you need to top it up. APTT, so that value is less than 1.5 control. And if you have any blood thinners, antiplatelets, or any NSAIDs, it needs to be withheld prior to procedure for the stipulated amount of time shown in the table. So of course, not everything is sunshine and roses. Prior to procedure, we will also need to explain regarding procedure and potential complications, as well as manage patient expectations. So for informed consent, we need to talk about nodule size reduction timeline. Okay, generally, you need to follow up over 1, 3, 6, and 12 months to assess volume reduction. And some patients will require more treatments depending on the number of nodules. And in some of these cases as well, there might be residual lesions. And when you have residual lesions, you need to go for additional ablation. And of course, after procedure, patient may experience pain. And also we need to explain about complication and side effects. Although they are rare, but they're there. Mainly it's voice changes, recurrent laryngeal nerve injury, bleeding. Medical history, basically on history of thyroid surgery or any medication. And also a patient will need admission and observation. So these are the complications that may occur. So you can get things like voice change. It's about overall rate of about 1.44%. It can be temporary or permanent. Lidocaine effect, temporary voice change due to numbing effect of the LA. Nerve stretching due to hematoma or hydrodissection fluid. And post-procedure inflammation can also cause temporary voice change. And also nerve fibrosis around the recurrent laryngeal nerve can result in permanent voice change. So you can see all these complications is mainly about the injury to the recurrent laryngeal nerve. Okay, so because of that, we need to have all these drugs ready. So during procedure itself, we give patients prednisone and also paracetamol IV, basically to reduce inflammation and reduce pain. And also we have this emergency drug, which is a cold dextrose prednisone injection. It's basically to inject it in directly to around the region of the nerve when patient actually experience some sort of voice changes during procedure. Okay, and this is our setup. You have the patient, you have the ultrasound machine, you have the ablation needles, and you need to have our cold fluid for hydrodissection and medication. And this is the product that we use. Basically, the active tip is only over here, and this will be cooled by saline. Okay, continuously cooling the shaft so that it doesn't go over the recommended temperature. Okay, so earlier I mentioned about hydrodissection. So why we need to do hydrodissection is because we need to separate and increase the distance between the target lesion and the critical structures surrounding thyroid. Okay, to ensure safety of ablation treatment and also to reduce incidence of complications. And most of the time, the structures of concern is always the recurrent laryngeal nerve, of course the adjacent muscles as well, the trachea, esophagus, even the common carotid and the IJV as well over here. All right, and also the vagus nerve. So the thing about vagus nerve is because it's in the name, vagus actually means wandering. It can have multiple different locations. So from here, it can be all around this position. Okay. So it's very important for us to actually hydrodissect and protect all these nerves. And this is another diagram showing that. So you have a type A, which is a medial type vagus nerve. B is a middle posterior type. C is a variation of the recurrent laryngeal nerve. Okay. And D is the usual location of the recurrent laryngeal nerve. And after sufficient hydrodissection, protecting all the structures at the site, the target lesion will then be ablated. And usually we use a moving shot or overlapping technique. Okay. Moving shot is the most common one that we use. So technical factors affecting volume reduction rate. So of course, it depends on operator skills and experience. And we usually burn in low voltage because you want to avoid carbonization. Okay. And we actually ablate nodular margins as well. As the nodule margins are ablated better, the less risk of recurrence as well. Elastography values, if the elastography values are below 60 kPa, tend to have higher volume reduction rates, while those with macro calcifications have lower recurrence rates and lower reduction rates. Hydrodissection, we use cold fluid to separate nodules from surrounding structures to prevent thermal damage and also to avoid heat sink effect. So over here, we don't do RFA, we tend to do microwave ablation. Okay, it is less susceptible to heat sink effect versus RFA, and it's more predictable. So for follow-up, okay, this is how we count our volume reduction rate. So it's the initial volume minus the final volume divided by initial volume times 100. So our treatment goal is actually to aim for volume reduction rate of 50%, and volume reduction rate is higher in cystic nodules than solid nodules. Okay, generally cystic nodules they get better, okay, versus solid nodules. They usually respond very well to our treatment. Okay, for follow-up neck ultrasound, it's recommended at 1, 3, 6, and 12 months post-ablation. And through this ultrasound, we actually look at the volume reduction, we look at the nodule appearance, vascularity, and areas at risk for regrowth. Okay. And meta-analysis of outcomes in RFA for benign thyroid nodules reported a pooled volume reduction of 64.5% at 6 months, 76.9% at 12 months, and 92.2% at 36 months. Okay, so you may wonder actually, with all this ablation, do you actually need a thyroid function test right after the procedure? So biochemical evaluation is not routinely required, okay, for monitoring thyroid function after ablation procedures, except if you're dealing with a hyperfunctioning thyroid nodules. You know, when hyperfunctioning thyroid nodules, sometimes when you burn it, patient actually develop hypothyroidism. Okay. So additional ablative sessions, nodules that fail to demonstrate adequate reduction in volume, more than 30% by 6 months following the procedure, we actually need to consider additional ablative sessions. And any nodules demonstrating regrowth, also we actually would recommend the patient to go for another session of ablation. And so far, these are the cases that we have done in and we only have about 13 so far until May 2024. And I'm going to show you some cases that we have done. So for case 1, this is actually our first patient. She's a medical personnel herself, and she actually had this solid nodule. And this nodule actually, they did FNAC, and it come back as a benign follicular thyroid nodule. Okay, this is the first lesion that she has. And second one over here as well, this is a mixed solid cystic nodule, and FNAC come back as colloid nodule. So over here, we did her ablation. Okay, it's done using this ecothyroid antenna, and the solid cystic nodule on the right upper pole and right upper pole solid lesion. Both they are actually ablated using the moving shot technique. Okay, 30 watts, and total time needed is about 26 seconds for the solid cystic nodule. The solid nodule is about 1 minute 30 seconds. And follow-up 2 months later actually showed the right upper pole solid cystic lesion is no longer seen. Like what I mentioned earlier, cystic lesions generally show better response. And post-ablation changes of the right thyroid nodule, the solid nodule actually has a reduction of 56%. And this patient, unfortunately, I only have the follow-up at 2 months because she's a medical personnel herself. She'd rather, just do her own ultrasound and her own follow-up. Okay, case number 2 that I will share is a cystic nodule, predominantly cystic nodule. So it's cystic with some solid component over here. So 18 May, this is what we did. We just did aspiration at the time because patient had some compressive symptoms. So basically, this is just for symptom relief. And 1 month later, we actually planned for ablation. And this is the lesion itself. Okay, you can see the cystic component is no longer that dominant. And on the day itself, we actually injected some alcohol into the cyst, and the solid component was actually ablated over here. Okay. And follow up 3 months later, you can see the volume is getting smaller. You don't see the cystic component anymore. And at 6 months, it gets even smaller. Okay. So this is the general timeline. Initial volume is about 36.9 mils. And the final volume at 6 months, it's about 0.5 mils. So it's a 98.6% reduction in size. Okay. Case 3 is a primary hyperparathyroid patient. Initially planned for surgery, but high risk due to ectatic ascending thoracic and arch. Okay, and the size wise is about 1.8, 2.2, 3.3. And for this patient, we actually did the technetium study as well for her. So basically, this is just to make sure that it is just coming from this right parathyroid adenoma, and there's no ectopic adenoma seen anywhere else. So on 28th of May, we pushed her, and she come for this ablation using this echo thyroid antenna 16G, and we burn it for a total of 2 minutes. And actually, this is on the day she was admitted on the 28th, and immediately after procedure, you can actually see a drop in the PTH. Calcium levels are, I would say, quite stable. There's no hungry bone syndrome, and phosphate is slowly climbing up. And 1 month after follow-up ultrasound, because it's quite recent, we actually see a volume reduction rate of 56%. So take-home message, thermal ablation for benign nodules is an alternative to surgery. And thermal ablation is effective in relapsed cystic lesion or residual solid nodules following internal ablation. Spongiform nodules are better candidates than solid nodules for thermal ablation. And thermal ablation is associated with low rate of major and minor complications. But the adverse effects are potentially severe, and follow-up is needed for 1 year. So it's 1, 3, 6, and 12. And this is just a reminder of the algorithm. So initial evaluation in the clinic, blood test, and then you send patient for imaging. So after imaging, you need to have a FNA of the lesion that the patient wants to ablate, at least 2 samples if it's a solid, and if it's a spongiform, you can only go with 1 sample, it's fine. And then patient will be referred for thermal ablation. And after that, follow up for 1, 3, 6, and 12 months. Okay, thank you. So this is our team, and we are actively collaborating with other departments as well, like nephrovascular. Okay, so anyone have any collaborative ideas and stuff like that, you can always approach us. Thank you.
Okay, thank you, Kim Wong, for your talk. There's one question from the audience. The question is, what are the long-term cancer risks on people treated with ablation?
Okay, so I don't think we have a data on this yet, and right now we actually don't aim for any malignant lesions. We only do benign thyroid lesions, which are confirmed through 2 times cytology, which is negative. Then we go for this ablation, or else we wouldn't. We'll still recommend surgery, because no matter how you burn, there's always a residual tissue there. Okay.
Yeah, Dr. Gan from nephrology said, great talk, Dr. Chan. And he also commented that end-stage renal failure patient tends to have secondary hyperparathyroidism, which may become tertiary hyperparathyroidism. So actually, this kind of patients are really not fit for operation and thus referred to us for minimally invasive treatment. So I think we have started a few cases. I think we're the only center who have been doing parathyroid ablation, and this is for the past year. This is our statistics, and we wish to get more referrals. So we really urge the primary team to refer to us. You can either see the ENT, nephrology, or the endocrinologist. So if any patients with large thyroid nodules that are not fit for surgery or does not want surgery because of other reasons, would be the best treatment. However, I'd like to emphasize that these lesions must be a benign lesion. We malignant lesions. Any other questions from the floor? If not, I would like to thank Dr. Koo and Dr. Chan for speaking in the breakfast talk today, and we look forward to seeing you next week at the breakfast health talk. Thank you, everyone.
Thank you.